29 minutes now. For 28 minutes.
Yeah.
Okay.
Yeah.
So leave time for Q&A or no, just go straight to the end of the time.
You can leave time. A lot of times we run over and people stay on. So,
Okay,
yeah, it's not a hard stop by any means.
sounds good.
All right, everybody. Well, thanks for logging on today. Today we have Dr. Michelle Kittleson, who's going to be joining us to talk about, as we continue some didactic talks in the realm of heart transplantation. She has many titles and accomplishments in her career. So we could spend the half an hour here talking about all of those things. But just as we had mentioned, probably the thing that we should be most proud of is she is an alumnus of our medical school here at Yale. Class of 99 is what she had just mentioned. So we're very happy to have her join us today to talk to us about heart transplantation and excited to see what she has to share with us. Thanks so much.
Amazing. Thank you so much. Yes, I have such fond memories of Yale, greatest place in the world. So thank you for having me to give this talk on heart transplantation outcomes and complications. I have no disclosures. I'm going to start by framing the talk with two questions, clinical cases, and then I'll give you the answers at the end, but you might know them already. Question one, a 40-year-old man who is 8 months post-transplant presents with fever and diarrhea. Medications, tacrolimus, MMF, prednisone, aspirin, pravastatin, and lisinopril. Labs are normal except a low white count. Is this most consistent with cytomegalovirus, pneumocystis, Epstein-Barr, or mycophenolate? And question two, which of the following is the most common malignancy after transplantation? Lung, colon, PTLD, skin cancer, or breast cancer. So this talk is focusing on outcomes and complications. So let's start with outcomes. This is a figure from the 2019 ISHLT registry report, and I show it to illustrate a number of important points. Number one, if we look at the ends here, over 100,000 patients have undergone heart transplantation over the past 2.5 decades, making heart transplantation truly an established treatment management strategy for advanced heart failure. Second, we see increasing survival in subsequent eras due to better techniques throughout patient candidacy and post-transplant management. And third, we see that median survival in the current era is about 12.5 years, which is certainly better than anyone can expect from end-stage heart failure. However, while patients do well, outcomes do differ by the indication for transplantation. And as we see here, patients with non-ischemic cardiomyopathy tend to do the best. Patients undergoing retransplantation tend to do the worst. I don't think this is a medical mystery because you add up your additional comorbidities, those will impact your survival. When we think about early mortality, what are those risk factors? And again, it all makes sense when you think about your clinical experience. Those patients who are sicker going into transplant, say on ECMO, congenital heart disease, MCS device, redo transplant, are going to do worse. The patients who are older, recipient or donor, high BMI, worsening kidney function, more ischemic time. So these are the things we think about. And then the ones we try to focus on really, what's modifiable and what's not. Well, we should be proud that transplant era patients do better, and having a heightened awareness of the increased risk of those patients on VAD, ECMO, or redo transplant. Now, we don't just think about mortality, however, quality of life matters too. And we look at Karnofsky score, a measure of functioning, we see that the majority of patients have a score of 70% or higher, which is essentially independent functioning, and return to work is almost 50% by 5 years after transplant. Now, we can say that in the United States, perhaps one of the reasons that patients don't return to work sooner is because of this crazy system we have where health insurance is tied to employment or disability, and that might dissuade some patients from returning. So bottom line, patients do well, patients do better in subsequent eras, patients feel better. But there are, of course, threats to their longevity. When we think about causes of death, you're looking at this slide and you're saying, why is she showing us such a busy slide filled with all kinds of numbers? How are we supposed to digest this? Well, let me show you some patterns. When we think about early survival after transplant, the most common causes of death would be multi-organ failure, rejection, and infection. Whereas later after transplant, we think about cardiac allograft vasculopathy, malignancy, and kidney failure. And this tension early between rejection and infection and late between allograft vasculopathy, malignancy, and kidney failure really encompasses that tension of the balance of immunosuppression, right? Because our goal is to achieve a state of quiescence whereby the body accepts the donor heart as its own. Early after transplant, if you give too little, you worry about rejection. And vasculopathy, essentially a chronic form of rejection. And then if you give too much immunosuppression, early on, we worry about infections. But then later on, we worry about malignancy, since our immune system doesn't just patrol for microbials, it also patrols for any foreign cell like cancer cells. And then, of course, long-term toxicity to the kidneys. So that's how we think about the long-term threats to a transplant patient's survival. And what I want to cover today specifically are 4 of those threats to long-term outcomes: allograft vasculopathy, infection, malignancy, and kidney failure. So let's dive into cardiac allograft vasculopathy. No surprise that the farther out you get from transplant, the more likely you are to develop allograft vasculopathy. About half of patients have some evidence on angiogram by 10 years post-transplant. And what's really kind of discouraging is that this is the Achilles heel of transplantation, and that there's been little improvement in our ability to prevent vasculopathy over the eras. And it's important to remember that cardiac allograft vasculopathy is not the same as coronary artery disease in a non-transplant patient. Non-transplant patients are often symptomatic with angina, might have an NSTEMI or STEMI, acute coronary syndromes, whereas allograft vasculopathy, typically patients don't have symptoms due to denervation, though there might be renervation to an unpredictable degree as the years go on after transplant. Often there are more non-specific symptoms like fatigue or just show up to clinic with a reduced EF. In non-transplant patients, there's often epicardial focal lesions that are easily stented by our interventional colleagues and their oculostenotic reflex. Cardiac allograft vasculopathy, on the other hand, tends to be a panvascular process with distal pruning and disease in the microvasculature that can lead to restrictive physiology, the stiff heart, the ongoing ischemia. Non-transplant patients typically slow progression. If your angiogram's normal, chances are it's going to be normal a year later. And a transplant patient, all bets are off. You can have rapid progression triggered by things like episodes of antibody-mediated rejection with nothing to something horrible within a year. Lesions in non-transplant patients tend to be eccentric, but in the concentric lesions of allograft vasculopathy mean that the degree of the stenosis may be underestimated by traditional angiography, and thus intravascular ultrasound may be a better measure. And these plaques are not typically lipid-rich and atherosclerotic. They're a form of a chronic rejection with fibrointimal proliferation, which means they're harder to target with standard CAD therapies. Because a picture is worth 1,000 words, let's look at some. This is someone with totally normal arteries on the donor angiogram. And by year 4, you can barely see the arteries at all. This carries a very poor prognosis, which is why we often have autopsy specimens of these hearts or explants when they've undergone redo transplant. And you can see that fibrointimal proliferation that's essentially obliterating the coronary artery lumen. So if you think about risk factors and ways to prevent it, well, increased donor age, male donor, positive CMV status, recipient smoking, ischemic etiology, recipient hypertension, diabetes, hyperlipidemia, I highlight those because those are the only ones that are really modifiable. So how do we prevent CAV? We use typically what we use in non-transplant patients: aspirin, we control hypertension, statins, diabetes. We know that mycophenolate mofetil is better than azathioprine, essentially now of historical interest when we think about transplant immunosuppression and the proliferation signal inhibitors. But of course, statins are the wonder drug. We know this landmark trial from my boss, mentor, and colleague, Dr. Kobashigawa, from decades ago, showing us that patients on pravastatin have less rejection, CAV, and better survival. And that's why the most recent iteration of the ISHLT guidelines tell us this is a class 1 indication regardless of lipid levels and can lead to the primary prevention of CAV. What about the proliferation signal inhibitors? They are clearly superior to azathioprine and MMF when we look at the progression of cardiac allograft vasculopathy by intravascular ultrasound. Stands to reason, as these agents, sirolimus and everolimus, are also in drug-coated stents to prevent that fibrointimal proliferation of in-stent restenosis. So one of the reasons to use proliferation signal inhibitors is cardiac allograft vasculopathy. What about intravascular ultrasound? So here's a picture of an intravascular ultrasound. Patient 1 at baseline, lumen looks fine. Patient 2 at baseline, lumen looks fine. But now at 1 year, epicardial angiographically, these arteries might both look okay, but when you look at the lumen under intravascular ultrasound, you now see this crescent-shaped encroachment from fibrointimal proliferation. So is this knowledge, the change between baseline and 1 year on the intimal thickness of the artery, useful? Well, it kind of depends. We have the classic study from 1997 that showed in the change in maximal intimal thickness leads to an increased risk of death and graft loss after transplant. But that was a long time ago, and there's been a lot more advances in our care of patients with heart transplants. So a follow-up study that took a different era, 2009 to 2016, in fact showed that this was no longer as predictive. So programs performing IVUS, it is center specific, but I think it's important to recognize that the strength of benefit may have been attenuated with advances in the current era. It's important to know your CAV nomenclature. 0, no disease. 1, nothing's important. 2, one thing important. 3, there's a lot of bad stuff going on. Which one do you really want to know? You want to pay attention to 3, because ISHLT grade 3 portends a bad prognosis. Here's a really nice study that went through that. It took patients years after transplant and showed very beautifully the progression. Everyone starts out at grade 0 because we pick great hearts, but over time, the proportion of patients who have grade 1, 2, or 3 disease increases, and there's no medical mystery here. The more CAV you have, the worse your outcomes. 15-fold increase mortality over time if you have grade 3 CAV, which is why this is an indication for redo transplant evaluation. Does PCI help? Well, if we look at mortality in patients who've undergone PCI versus grade 3 CAV, it looks like they may do better, but actually in the adjusted survival, probably not. So when we stent patients with CAV, their epicardial disease, it's hard to know if we're treating them or we're treating ourselves because we cannot address the panvascular microproliferation process. One nice way to assess who truly needs an angiogram is the CAV trajectory score that takes into account 6 parameters to put patients into a trajectory whereby you can predict over the next 10 years, will they get CAV and what their survival will be. And in our program, we're using this score to decide who needs frequent yearly angiograms and who might need less frequent angiograms every 5 years or less. So what do the guidelines tell us from the ISHLT? Do an angiogram, less frequent if they don't have CAV or have kidney dysfunction. They do give IVUS a class 2A indication. Non-invasive assessment is also PET or CCTA preferred over distress echo or SPECT. And then interventions, again, CABG understandably being less desirable because why would you waste a sternotomy on a CABG when you may need it for redo transplant? So let's move on then to other causes of decreased survival in our patients after transplant. What about infections? I'm going to go through classic infections I want you to know about. CMV is a classic one that every heart transplant clinician should be aware of. As you know, anyone who's had CMV before can have reactivation. The reactivation can come from the heart, or it can come from the donor heart or from the patient themselves. There can be direct or indirect effects. Patients can prevent with the fever, malaise, myalgias, myelosuppression, increased liver enzymes. They can have colitis, pneumonitis, retinitis being rare in solid organ transplant recipients. And it puts them at increased risk for other bad things, which is why we'd like to prevent it: PTLD, rejection, CAV. This is a figure that is still as important as it was almost 2 decades ago when it was published. You need to know what infections to think about when. Early on, it's all the hospital-acquired stuff. Then we get into more of the opportunistic, like the Cryptococcus, Mycobacterium, and then farther out, the Aspergillus, the Nocardia, the late viral infections. So what do the ISHLT guidelines tell us about how to prevent these? Well, for CMV, you'll give valganciclovir. The duration will be sent not. The mismatch should have the longest duration. If they're CMV neg-neg, you don't have to spend the money on valganciclovir, which also does double duty prophylaxis against HSV, and just give acyclovir. And EBV can't be treated, so we don't really monitor it. Pneumocystis, of course, Bactrim is our friend. It also helps with toxo. And that they're sulfa-allergic, atovaquone, which patients dislike because it's expensive. It looks like yellow paint and it smells like rotten eggs. So dapsone is a fair alternative, but you got to check your G6PD to make sure they're not deficient, which may cause hemolytic anemia, and doesn't work for toxo. So if they're toxo mismatch, that's off the table. Coccidioides, for us in California, we have Bakersfield, which is our cocci endemic area. So they will get an azole for at least 3 to 6 months. And then these infection prophylaxis are used for the first year and after augmented immunosuppression for rejection. And of course, we can't forget about vaccines. Give them all the vaccines as long as they're dead, inactivated. We typically wait 3 or 6 months after transplant before administration. Moving on then to malignancy, another enormous Achilles heel in our patients' long-term survival. When we look at post-transplant malignancy, we see that it's quite common that by the time you get to 15 years after transplant, almost half of patients will have had some form of malignancy, and the most common will be skin cancer. But as you well know, this isn't the freeze something off once a year or so. This can be incredibly disfiguring, invasive, and even metastatic. The most important study on how we should manage our patients' immunosuppression with malignancy is stolen from the kidney transplant literature. This is a classic paper that took kidney transplant recipients who had had one squamous cell carcinoma and then randomized them to either continuing their calcineurin inhibitor or switching their calcineurin inhibitor to a proliferation signal inhibitor, sirolimus, and they found a marked reduction in the risk of recurrent squamous cell skin cancer after 2 years. So we can steal this from the kidney transplant literature, and we can extrapolate it to all forms of cancer, knowing the importance of attempting a CNI-free regimen, because the calcineurin inhibitor is not only the best immunosuppressant, it's also the most likely to cause cancer. PTLD is a classic malignancy you should know about. Post-transplant lymphoproliferative disorder is a B-cell lymphoma, EBV associated in about 50% of cases. It has a bimodal distribution. You might see it really early within the first 2 years or else late. And more immunosuppression, including the use of things like ATG, does increase risk. Patients can present with those B-type symptoms we all memorized in medical school: fever, malaise, pharyngitis, extranodal masses, abdominal with perforation, CNS disease. Our job as heart transplant clinicians is to back off immunosuppression, and the oncologist, hematologist will give them rituximab with CHOP. What do the guidelines tell us about malignancy? Well, breast, colon, and prostate cancer screening should occur as for the general population, and of course, skin cancer surveillance, which is the greatest detriment to their quality of life and survival from a malignancy standpoint. Now, the guidelines give a weak indication for converting to a CNI-free regimen, which may also be because there's risks to this in increasing the risk of rejection, and these things must be balanced. The final issue to talk about is kidney failure. Not much to say, except it's common. And if we look at severe kidney dysfunction after transplant, a sizable proportion of patients end up on dialysis or undergo kidney transplant within 10 years. And it clearly is all due to the cornerstone of our immunosuppressive regimen, the calcineurin inhibitor. So we talked about the role of the proliferation signal inhibitors for CAV. We talked about it for malignancy. Well, also it can be used to combat the nephrotoxicity, but the reduction in nephrotoxicity from withdrawal of the calcineurin inhibitor comes at a cost. So this is figures from the scheduled trial, a randomized controlled trial, where patients were randomized to a CNI-free regimen relatively early, 3 months post-transplant. And lo and behold, the eGFR was a lot better if you took away the CNI. The IVUS also seemed better, but they had a lot more treated rejection, and they had more edema pneumonias. Similar results from the Mandela trial. So we can say it's wonderful for the kidneys, perhaps not so bad, but perhaps increased risk for the heart, so we choose these patients wisely. What do the guidelines tell us? They say that the eGFR is low, there's albuminuria, rapid decline in kidney function. Send your patient to a nephrologist. CNI exposure should be lower to the minimal level, and mTOR inhibitors may provide long-term benefit balanced with the risk of adverse events, all very consistent with our clinical trial evidence. So to summarize, we know that cardiac allograft vasculopathy is distinct from non-transplant coronary artery disease and portends a worse prognosis. When we think about infections, know your prophylaxis and remember that CMV is a classic post-transplant infection. Malignancy, skin cancer is the most common and PTLD is the most classic. And with kidney dysfunction, we have to attempt CNI minimization. Now, I want to circle back and go back to those questions we started with at the start of the talk. And if you didn't know the answers then, you definitely know the answers now. So a 40-year-old man who's 8 months post-transplant presents with fever and diarrhea. His medications include tacrolimus, MMF, prednisone, aspirin, pravastatin, and lisinopril. His laboratories are normal except a low white count. And the most likely cause of this presentation is, of course, cytomegalovirus. Pneumocystis would expect to give lung findings. EBV might have similar findings, but we typically don't check for it anyway because it's not treatable. And of course, mycophenolate mofetil will give you leukopenia, but shouldn't give you fever and diarrhea. I'm sorry, could give you leukopenia and diarrhea, but should not give you fever. And you never assume it was MMF toxicity until you've ruled out the treatable serious causes. Question 2, which of the following is the most common malignancy after transplantation? Lung cancer, colon cancer, PTLD, skin cancer, and breast cancer. Of course, the major risk detriment to our patients' morbidity and mortality is skin cancer, which is why we have such a heightened awareness for dermatology surveillance and consideration of the CNI-free regimens. Well, there you have it. That is heart transplant outcomes and complications. And I'll send it back to Dr. Beasley if anyone has any questions for me. Thank you so much for the opportunity.
Thanks, Dr. Kittleson. That was fantastic. We do have one question for you already in the chat, and this just basically involves your use, or how would you manage immunosuppression in somebody who has an infection? And then there's a second one that just came in that we can get to from a second. for a
Okay,
second.
sure.
Mhm.
How do you manage immunosuppression in someone with an infection? It depends on a lot of factors. Depends on how serious is the infection and how far out is the patient from transplant and what's their personal risk of rejection, right? Because you're trying to balance infection and rejection. We'll say to start with that if the CNI is the cornerstone of the immunosuppressive regimen, then the MMF, the antimetabolite, is the supporting actor to the lead actor, right? It's the one that you can play a little fast and loose with. So that's the one that will have the greatest temptation to just back off on whenever we need to. So for example, a patient comes into the hospital on 5 of pred. We never weaned it off because they had rejection in the past. Some tacrolimus and MMF 1000 BID. Now they're diagnosed with Aspergillus pneumonia. We'll feel very comfortable backing off on that MMF, maybe 500, maybe 250, while we're treating the Aspergillus. Say the same patient comes in, but now they're on tacrolimus and they're on sirolimus. They're off pred. They never had rejection. We switched them to sirolimus because they were a CMV mismatch. We wanted to reduce their risk of CMV. We know that sirolimus increases your risk of fungal infections. Now the patient is Aspergillus, take away that sirolimus, maybe keep them on TAC monotherapy because their risk of rejection was low. And when the Aspergillus is treated, add back the MMF. Say you have a third patient who's on TAC, sirolimus, and prednisone because they have high donor-specific antibodies, sensitization, but they've never had rejection. And now they come in with Aspergillus. That's a reason to still stop the sirolimus, but don't stop it. Come switch it to MMF because they're also sensitized and keep the pred on board. So that's kind of the algorithm we use. Think of the patient's risk of rejection, the patient's risk of infection, how far out they are on, and what kind of infection they have.
Thank you. Second question here, I'll just read it out for the group as well. Two questions in this one, but the first one is, when using PSI instead of CNI, does your institution have a protocol for increasing MMF dosing?
Yeah, hugely important. So when we're thinking about a CNI-free regimen, we're trying to predict the future. Is this patient going to have rejection when I do this? Because every year or so, someone will come in crashing with life-threatening catastrophic rejection if we choose wrong. So how do we choose right? Typically, we want them still on 5 of pred. In fact, if we've weaned them off their pred for some reason, we sometimes will add it back on. We will not try a CNI-free regimen in someone who's had prior rejection, current donor-specific antibodies, or we're worried about adherence in such a way that they won't understand the regimen and show up for the follow-up to get their levels checked, etc. So low threshold to restart 5 pred if they've been weaned off it. MMF dose should be ideally 1,000. Now, 1,500, I'm sure we start everyone at 1,500 MMF when they leave the hospital after a fresh transplant. How many patients are still on 1,500 BID by a year? Practically no one. They all have GI upset or some leukopenia. So 1,000, 750 to 1,000 would be our sweet spot BID for tolerating an adequate dose of MMF to be off the tacrolimus, to be on the sirolimus.
Then the final question is in regards to risk for CAV. So does donor history of cocaine use, methamphetamine use, smoking, diabetes, older age greater than 50 also impact risk for CAV? And is there any data out there for this?
Yeah. So smoking, definitely. Diabetes, definitely. Age, definitely. Not sure about meth. I don't think there is data for cocaine. It's also difficult, isn't it? Because we're always, again, trying to predict the future. It's how sick is my patient? Because every day on the heart transplant waiting list is borrowed time, especially for patients who are listed status 1 through 3. And then am I going to trade their immediate death on the waiting list for a long-term complication of CAV? So it's very hard to judge those things, isn't it? And I think it really does come down to what is your threshold of accepting a higher risk donor for a status 6 who's hanging out at home versus a status 2 who's just barely hanging on with Impella support. So I think that always factors in. And there's also the confluence of risk, because we don't just worry about the long-term risk of CAV when we pick donors. We worry about like primary graft dysfunction. We know the farther away the donor is, we know, so the longer ischemic time lifetime, the older the donor, the comorbidities can also impact that. So if it's a local donor who's got a lot of other factors, maybe I'm okay taking it. If it's a donor who's already 4 hours away and my recipient's a status 6, I'm going to be less likely to entertain other risk factors. So I don't think there's a one size fits all answer. It's how do you stack up your risk factors and concerns?
Do you have time for two more last
I
questions?
do. Yes.
Okay. All right. So these will be the final two. And then the questions are in regard to the use of statins, given CYP interactions. Is there possibly data for the use of other statins? And then what's your use of beta block, or what's your thoughts on beta blocker use in patients that have SVT?
Great. So statin. So of course, pravastatin is typically preferred because it doesn't interact with cytochrome P450. We worry if you're on a calcineurin inhibitor and you're on a other statin that you can have decreased metabolism of the statin, leading to concern for rhabdomyolysis. So if you're going to give another statin, you give half max dose as the most you'll give. So atorva 40 or rasuva 20. So we put everyone on prava right after transplant. Just set it and forget it. What's the LDL threshold? I don't know. I don't think anyone really knows what it's supposed to be. We sort of have, it depends on which doctor is reviewing labs that day, honestly, in transplant clinic. But typically, if you've had any CAV, then we'll bump you up to atorva 40 or rasuva 20. If your LDL is above, is it 100? Is it 130? Is it 70? You'll often be bumped up. So all to say, we'll use an excuse if we have it to switch them to a more potent statin if we can. And especially for those patients who had early ischemic disease, their cholesterol was always a problem to begin with. It's still a problem. And then low threshold for a PCSK9 inhibitor if they don't tolerate a statin and they have any other risk factors that make us concerned, or existing CAV, well tolerated in transplant patients. Beta blockers. So we know that beta blockers are poorly tolerated, typically with exercise intolerance due to denervation of the transplanted heart, because they rely on circulating catecholamines from the adrenal medulla. They don't have that postganglionic release, so that they're going to have a longer warm up, longer cool down that's even more pronounced when you put them on a beta blocker with fatigue and exertional intolerance. So my first question, if you say, would you use a beta blocker for a transplant patient with SVT? I'm like, wait a minute, why do they have SVT again? Like, I want to get a sense of what's going on first. Like, is this like a reentrant tachycardia? Oh, you got the heart from someone with a reentrant tachycardia. Well, then just have EP zap it. That'll be super effective. Is it a flutter? Have EP zap it. It'll be super effective. If they have AFib, well, wait a minute, why are they having AFib? Is this like a CAV thing? Is this a rejection thing? Is this, they got an old heart thing? Let's sort that out first. And after we've sorted that out, then we can say, a beta blocker may be a necessary evil for symptomatic benefit in some patients with a low threshold to back off or stop if they have any impact on their quality of life.
Wonderful. Thank you so much, Dr. Kittleson. Fantastic talk, fantastic response to these questions. And thanks everybody for joining us this afternoon or this morning, depending on where you're at in our United States of America. And look forward to catching up with everybody at our next talk. I'll be sending out further invitations in the coming week. So we do have more talks lined up for the fall. I just have been busy and haven't gotten around to that. But stay tuned. Dr. Kittleson, again, thank you so much for the time today.
Thank you. It was great.
All right, bye-bye.